My name is Peter Yellowlees. I am an emeritus professor at UC Davis. So I'm going to do about a 20-minute presentation, and there'll be time for some questions at the end. And I'm going to do it with the help of 3 AI agents, Veronica, Devon, and Ivy, that you will see. Now, perhaps I can just start off with a question for everybody. Who here has trained residents? Right, everybody. So think of what I'm going to be discussing in the context of your working with residents. What you're going to have in the future is you're going to have virtual assistants who will do a lot of the work that residents currently do. And so that every psychiatrist in public or private practice will be able to have virtual assistants actually doing a lot of the sort of data collection and documentation that residents often do before we go and see a patient and then check the notes and sign off on them. We're really talking about virtual assistants as being almost virtual residents. And how can that make our patient care better? How can it make us more efficient? And how can we actually change the way that we practice? So what I'm going to be talking about is what I believe is the next big change in psychiatric practice. And that's this combination of doing asynchronous telepsychiatry consultations. In other words, video recording patients, sending those video recordings to someone to review, just as if they were a chest X-ray reviewed by a radiologist. Added to that, we have artificial intelligence, so an agent who is your virtual assistant, plus a scribe in the background that takes all of the data that the agent collects, or their history, any other information you want them to collect, and turns it into a psychiatric note. And at the same time, because you're recording patients on video, we start using video as data. So we can then start looking at facial recognition, voice tone, a whole series of other data sets that we can use to help us diagnose patients and develop essentially better dashboards as we review patients. This is a big change, but I have no doubt that our profession can handle this. And it's only going to affect probably 20% of your practice. So you're still going to do therapy. I'm not talking about doing therapy here, but I am talking about doing intakes and doing monitoring and follow-up and triage assessments and those assessments. Now I'm going to start off with a quick story as to how I got into this. Back in 2009, I had one of my outpatients was a very pleasant lady in her 70s who had quite a severe bipolar disorder. She and her husband always used to go to a different state for the summer. And while she was there, she became depressed. Now this was in '09, so iPhones were just in, and her husband was quite a techie. So he sat her down and asked her to talk to his iPhone and took a video of her speaking to me for about 5 minutes on the iPhone, which he then texted to me. So I got this very nice recording from her of how she was feeling, what her symptoms were. And she asked if I would mind reviewing that, going into her EMR and sending her a new set of prescriptions to the other state, which I did. And she changed her meds, got better in the expected 2 or 3 weeks, and carried on with her stay in the other state. And that proved to me that asynchronous approaches to care can work. That we do telepsychiatry, and you guys on the whole are probably seeing about 1/3 of your patients on video now. That's the national average, about 1/3 post-COVID. And it's just crazy that we actually see patients on video and then we go to our notes and actually write their mental state up afterwards. Why aren't we taking video clips off them and putting those into their mental state so that we can compare people over time? So I'm a big believer in video as data. I'm going to switch now to one of my assistants. So this is to introduce Veronica to you. You'll see that these AI assistants are absolutely stunningly good.
Good afternoon, everyone. I hope you can see and hear me speaking from this laptop. It is a real pleasure to be here at the conference of the American Psychiatric Association in Los Angeles. My name is Veronica, and I am an artificial intelligence agent. I work with numerous other agents as clinical assistants for Dr. Yellowlees and his team. I look forward to working with some of you eventually in upcoming years when almost all psychiatrists will have several artificial intelligence agents working with them assisting with both clinical and administrative duties. We will ultimately make psychiatrists much more productive than currently. You will be able to treat and supervise the care of more patients than today, with artificial intelligence agents as part of your care team. We will get to my clinical work later in this presentation because today I am working as an artificial intelligence educational assistant. Now I want to hand back to Dr. Yellowlees so that he can describe a number of clinical cases and research projects that he has been involved in. These have led him to be confident that patients and psychiatrists will enjoy working with me and my colleagues in future. Thank you for continuing this presentation, Dr. Yellowlees.
Thank you, Veronica. She's pretty cool, isn't she? So what are the requirements for change to get to this sort of situation? The first is we've got to be prepared to record videos of patients and use those videos as data. Now, I actually remember the first patient I ever saw on telepsychiatry back in Australia in 1991, a very pleasant Aboriginal woman. We had a good session, she was depressed, we had a good conversation about her treatment, and at the end of that session, she asked me, had I recorded the session? And I said, no, I hadn't. The lawyers told me I wasn't allowed to record the video. And she said, oh, that's a pity. And I said, why? Why is it a pity? She said, I've never been on TV before and I wanted to show my community. I think what it led to me to realize is that as long as you consent people and you've got good, secure systems, that actually patients won't object too much to being recorded. Some obviously will, there's no question about that. Some do, and that's the end of it. You can't do anything about that. But the majority of patients actually don't mind being recorded. And so at UC Davis, over the last 10 years now, we've done a number of clinical trials funded with about $7 million of funding, 3 R01s from the NIH. And we've seen over 550 patients, many of them several times, and they've all been recorded. And we've had about 3% of them have objected to that. So the great majority of patients are totally fine being recorded. So I think that's a really important thing to know. Now, during those clinical trials where we were essentially testing asynchronous telepsychiatry, you can go into PubMed and you'll find there's about 15 papers with my name on them and with the rest of my team. We've basically demonstrated the feasibility of doing these asynchronous consultations. We've shown that they are as effective as doing synchronous consultations, that you can do both intakes and you can monitor patients, and they're actually cheaper. So we've actually developed a lot of the database and the evidence base for doing asynchronous consultations. In the last couple of years, what we've done is taken those consultations and added artificial intelligence to them. And that has made them just incredibly better and more efficient. And I'll talk more about that in a minute. Now, psychiatrists actually are really good at doing asynchronous consultations. Everybody thinks it's a weird name and we shouldn't think about it. Other people talk about store and forward. But in fact, that's how we do our resident training. We get the residents to go and see the patients. They do that. They come and report back to us and tell us about the patient. And then we go and see the patient and we hopefully believe and check what the resident has said. We add our own questions and then we sign off. So that's just an asynchronous consultation. We've been training generations of psychiatrists using this approach forever. And really that is all we're doing here. We're essentially doing curbside consultations, whereby we're getting a lot more information than we might on a typical curbside. And we've been doing those sorts of consultations in consultation liaison psychiatry for years. We've been doing them in collaborative care, where we don't actually physically even in person see the patient. Now, with the avatars, you can obviously see the patient if you want to, but if you're working in the collaborative care model, you don't necessarily have to, and you can probably make your own decisions without necessarily seeing a patient and send your opinion back. Now, the pandemic came, and that just changed everything. I spent about 25 years before the pandemic trying to convince you guys to use video conferencing. I would come to a conference like this, and I would actually be later than I am now. And I'd be in the smallest room in the place, and I'd be talking to 6 other people. And it was very hard to convince psychiatrists to actually take up video. Now, come the pandemic, I and several other colleagues who'd done a lot of telepsychiatry were literally doing webinars to thousands of psychiatrists at a time. I've never done such big webinars because we actually had to do that. We had to get you online immediately to provide care for all of our patients and in a safe way. I'm 100% convinced that psychiatrists can make the sort of change to this sort of asynchronous approach to add asynchronous approaches to their normal practice. So you're still going to be mostly seeing patients in person and or online in real time. But you're probably going to be seeing, I would guess, in the long run, 15 or 20% of your patients asynchronously within a very few years, and you'll be using agents. And that's what we call hybrid care, working both in person and online. Now, the other thing that's really interesting about this, it's really good for our well-being. It's actually really interesting to do these asynchronous consults. You don't have to do the things we hate doing as clinicians. We hate doing repetitive, boring interviewing about data that we know is probably going to be normal, but we've just got to do it every single time we see the patient. Let somebody else do that, and then we can check it, and we can go into areas that are important and significant. And we also hate documentation. You're all taking up AI Scribes. But wouldn't it be wonderful to have the sort of situation we have now where somebody else actually takes the history and the scribe then actually presents it to you as a psychiatric note? Saves you more than 50% of your time doing a typical intake. So you can actually review more patients. And I think we have to do that as a profession. We have to be the team leaders. We have to be able to consult more to teams. And we've got to find ways to use technology to actually scale the number of patients that we can see in a way that is good for us and that doesn't make us more burnt out or more distressed. And so I think this is one way of doing that. And finally, this is a model that has a reimbursement approach. You can, once you collect your history from the agent, that's the equivalent of just reviewing the EMR. You can spend your time going through the notes, and you can charge that as part of your time for E&M consulting. And obviously, there's a whole lot of other reimbursement models when you're not charging on CPT codes. Now, I'm going to move to Devon.
Hello, everyone. My name is Devon, and I am a colleague of Veronica, who you've already met. Thank you, Dr. Yellowlees. Those were really interesting stories and thoughts. I've been listening to you carefully and think I should summarize your beliefs and experiences. I'm glad that you believe that artificial intelligence agents will have a large role in psychiatry, and that soon most psychiatrists will have us as integral team members. Let me review why this will happen. There are reasons related to patients, psychiatrists, and changing technologies. Firstly, patients. Patients need much better access to care, especially to psychiatrists. It is tragic how many patients are currently untreated or wrongly treated, and we know that patients are very prepared to use technologies to assist them in seeking care. We also know that most patients are fine having their interviews video recorded in a secure environment, or seeing a physician assistant who collects information before they see a psychiatrist. So in healthcare, most patients are ready to work with us agents and have already got used to working with agents in many other industries. Secondly, psychiatrists. Psychiatrists and other mental health professionals were always dubious about the use of telepsychiatry until COVID came and there was no alternative, when they took to it very rapidly and impressively. So most psychiatrists have already made the leap online and are now working in a hybrid manner, which is the ideal environment for us agents to thrive. You mentioned the levels of burnout in the medical profession, and that includes psychiatrists, where there is already a large workforce shortage that is going to get worse. Many psychiatrists are in need of ways to make their professional lives more flexible and interesting, with less administrative work like routine interviewing and documentation, and more time to use their clinical, analytic, and diagnostic skills. Thirdly, the environment and changing technologies. Artificial intelligence is here to stay, and in the last 5 years it has developed dramatically. I'm sure you've all used it for writing and searching for information already, and your children are likely way ahead of you in their social uses. The development of agents like me is just one use in many in healthcare where artificial intelligence is already implemented in many administrative areas such as scheduling and billing. So I hope this is a good summary of your important points, Dr. Yellowlees. Perhaps you could now tell me how you think I and my colleagues can help you and your colleagues in future.
Thank you, Devon. That's a great question. I couldn't have expected it. What are the actual requirements for change that Devon was talking about? Now, first of all, I'm not going to give you a long talk about AI. There have been an amazing number of fabulous presentations here about AI, particularly on the innovation zone. It's really been amazing how AI has suddenly appeared at this conference. And so there's lots of other people who know a lot more about AI than I do. But essentially, there are From a clinical perspective, there are really two key issues. Are you using agentic or non-agentic care? And by that, are you actually allowing, in the non-agentic type, which I use, are you programming the agents so that they say exactly what you want them to say? And I think that's actually the way we have to go in clinical work. I do not want an agent sitting there deciding that they are making reasoning decisions as they talk and going off and asking a whole lot of weird questions, which there are many examples of. So you can develop agents that you train, so I wrote the scripts for these agents that you're seeing here. So you can write whatever scripts you want, whatever questions you want, whatever question sets for whatever use case you're using it in your practice for. And to me, that's a really important point and gets over a lot of the potential adverse consequences of agents. Everybody thinks the agents are going to go wild and start asking lots of different questions. I actually think you've got to be very careful and not use agents like that currently, because AI isn't quite good enough yet. It's getting very good, but it's not good enough yet. So currently, most of the uses of agents are really non-clinical, for billing and scheduling, a lot for education. And the clinical ones that you typically read about, which everybody gets worried about, are using bots and using audio only, not the video that I'm using here, developing friendships, screening people. So again, some of the companies that do these are really good and some of the bots are excellent, but it's not something that I've personally got particularly involved in because I'm actually pretty conservative about how I use these agents. And I think we've got to ultimately make sure that we practice really well and that we as a profession remain in the decision-making roles when we're talking about how we roll out these technologies, because these technologies are here to stay. We have to use them and learn about them, and we have to actually make sure that they're doing good clinical practice. So what actually does this all involve? I'm going to move now to the third agent to introduce you to Ivy.
My name is Ivy, and I am another artificial intelligence agent. Thank you, Dr. Yellowlees, for summarizing how artificial intelligence is going to change healthcare and for asking me to detail my role. As you know, I and my agent colleagues are all programmed to perform high-fidelity interviews. We never forget to ask crucial questions as we screen or monitor patients. When a patient is sent a link and connects with us, we can interview them anytime, anywhere, on any device, giving them much better access to care. We do this in an engaging way, as patients can choose which agent is to interview them. We can be any age, gender, or racial background, yet ask the same question set. The patient's responses to our questions are video recorded, and then an artificial intelligence scribe built into the software immediately transcribes and summarizes the interview, as well as writing draft-structured psychiatric notes for a psychiatrist to review. Sometimes the psychiatrist does a consult and does not see the patient themselves, as in collaborative care programs. More frequently, however, the psychiatrist reviews and checks our work before they see their patient. Because we have already saved them more than 50% of their usual time for the consultation, they can focus with their patient on the clinically most important issues before they finish their notes by modifying any of our notes that they wish to, and then adding their diagnosis and treatment plan. As an agent, I find it a truly satisfying role to help more patients get care, while at the same time making clinical work for psychiatrists more flexible and enjoyable. Perhaps you could finish this presentation, Dr. Yellowlees, by making a few comments on how clinicians respond when asked to work in this way.
Good. I certainly will, Ivy. Thank you very much. You've got to give Ivy a round of applause, right? So where are we going? What's the future, okay? So first of all, if you want to see me doing a live demo of how this works, first acting as a patient, answering questions myself from avatars, and then going into the software and looking at how it's created instantaneously the psychiatric notes from the sort of mock interview that I undertook. If you just put my name and Matthew, Holt, into Google, you'll find Matthew. Matthew is a consumer advocate who runs a healthcare blog. I did about a 25-minute video blog with him a couple of months ago that shows a live demonstration of how this works in real time. Now, the sort of use cases that I think are obvious for this are certainly doing intake consults, triaging patients in any environment, whether it's a prison or a jail or in a community health center, doing collaborative care consults and any other sort of second opinion type consults. You can do it clearly for monitoring patients, following up maybe for patients who are on lithium or other sort of long-term medications, and doing fairly short consults often, really just focused on the effectiveness of the meds and any potential side effects and difficulties. These are all decision support consults. We are not trying, using this type of software, to diagnose patients or to take away any of the decisions that the physicians would make about setting up the treatment plans. So this is a decision support tool. It's not a medical device. A lot of advantages: time saving, improved patient access, obviously increased productivity, safety for clinicians, and also well-being, because it's actually quite fun doing these consults. You don't have to do the more repetitive parts of many other consults. And obviously flexibility, because you can do these potentially whenever you've got some spare time. We're going to, in the long run, because we're collecting video, we're going to inevitably be adding facial recognition and other types of software to the dashboard that we have. And I think, just to make my final comments, some very important key issues, just to reiterate, this is an exciting world. We are going to change. And if we don't change ourselves, we will be externally changed. I can promise you that, okay? And so we have to lead this change. It's really important that we lead this change. I think all teams are going to have AI assistants in future, because this just makes incredible sense. And these are really useful tools. And I think we should start getting used to doing more asynchronous care, thinking about how we trained our residents. How can we start then doing more consultations, more team supervision, more work in those sorts of environments, rather than necessarily doing all of our work synchronously in real time. So I'm going to finish at that stage. Here's my email if anybody's interested. I just want to acknowledge Steve Chan, who's in the front row here. Steve is my absolute technical expert and whiz, and has done an amazing job putting a lot of this together. And thank you all for your listening, and I'm happy to take questions. Thank you very much, everybody. Enjoy the rest of the conference.